All right, so, one of the first questions, sitting here yesterday listening to all the presentations about the dangers and the harms of various chemicals that are in our body, one might say, then why are we talking about glyphosate only, right? Because as Dr. Lodog said, it may not be the most significant of the chemicals that we are exposed to, but it's simply one that's currently in the spotlight. Right? It's being talked about. It's something that our patients are hearing about. And quite frankly, it's something that we can measure in our patients. And most of us know people with chronic diseases. And 5 years or so ago, I started hearing more and more about glyphosate. And I grew up in the Central Valley in California, which is a growing region, and have known farmers and friends who have died from Parkinson's and other related illnesses. And it started catching my ear. I started listening a whole lot more about the chemicals and what they were doing. And I listened to some presentations about glyphosate. And I don't know about you, but when I go to conferences, I like to be able to take the science home and make it practical in my office. And what I heard 5 years ago, sitting at an environmental health conference, was that there's this oogie boogie man out there that's glyphosate, among other chemicals. And the only study was in cows about how to get it out. That was the Gerlach study. And I thought, well, we have a little bit of different digestive systems than cows, so how's this going to work for our patients? And I waited a few years, figuring somebody out there would figure it out. And then 2 years ago, I was sitting in another environmental health conference, and they're mentioning the same study. They're still talking about Gerlach. And I'm like, are you kidding me? We haven't advanced yet in clinical practice. So I dove in. And I'm going to encourage all of you guys to start, let's take what we're learning in the office and share it so we can take this one more step, so we can figure out how to do this with our patients. So the purpose of the case study that I put together was to determine if chronic low levels of glyphosate exposure were of concern, because we're hearing about the big cases, right, with the leukemias and a lot of the bigger issues. But what about our patients? What about those folks who may have used Roundup at home in their gardens, or they walk their dogs at the local park, or they have kids that play? Should we worry about it? Does it even matter, right? Reviewing elimination efforts clinically over a period of 2 years with one patient. So this is only N of 1. But if everybody here went home with an N of 1 and started working on it, we could get an N of a couple hundred, right? Let's start figuring out what works. And then obviously just to contribute back to science and say, what's next, right? This is what I learned, but what do you learn? What can we do with a bigger case study? Because quite frankly, as I said, none of this had ever been done before in humans, at least hadn't been reported on in research. So I'm going to be able to skip a lot of what I put on the slides because it's been talked about a lot over the last couple days. But when it comes to chemicals, and this is where I'm going to encourage us to step out of our beautifully comfortable offices and get out and help with policy. Because when it comes to chemicals, there's such a low threshold with whether or not this stuff is going to get exposed to us. They use this LD50 level, basically saying that if it doesn't kill 50% of the animals tested, it has a low threshold, like it's safe, right? So chemicals that have been shown to have a low LD50 are approved for human use and consumption, and glyphosate was one of those. Now, mind you, all the early testing on glyphosate was done as glyphosate, the chemical alone. But in Roundup, the most commonly used chemical combination, and a lot of the others that it's in, it's never alone. It's always mixed with other chemicals and surfactants. POEA is one of the most common ones. And actually, a lot of the research that we're seeing, it's the combination of those chemicals. And it's the chemicals that are already in the soup that is our bloodstream and our fat stream and everything else that is it's binding with and it's mixing with that are potentially of concern. We talked about different uses that glyphosate has been approved for over the years. Now, the important thing to understand this is, well, wait, if it was approved for these uses, what is it also doing, right, inside of us? So it was a chelator to remove minerals and things out of pipes. Okay. It was used as an herbicide and it was used as an antimicrobial. So antibiotic. So it's causing some changes in our gut microflora. Primary metabolite that we're seeing in the urine is AMPA, and it also secondarily degrades to sarcosine pathway. And we heard Dr. Karazian talking about how chemicals bind to proteins. So we don't yet know all of the proteins that glyphosate can bind to and what tissues it's storing in, but that's one of them that's been shown in research. So it's ubiquitous, right? We're all exposed to it. Whether or not it stays in our bodies may make a difference between a lot of other factors. But it's found in food and non-food crops: wheat, corn, soy, cotton, sugar beet, rivers, lakes, watersheds, soil of residential yards, schools, campuses, public parks. It's everywhere. It's in our water supply, right? It's air, rain, surface, and groundwater, companion and farm animal feed, powdered milk and infant formulas, cotton products, including diapers, medical gauze, tampons, and other things. But it's found in the blood and urine of humans, including cord blood in newborns. So it's here. What do we do about it? Do we need to do anything about it? Does it cause harm in humans? So we did hear yesterday about non-alcoholic fatty liver, and I wrote this paper in December. I submitted it in December, so that was before the research just came out from San Diego this May, which really is a stronger bolstering of some of the research that I previously had found, but also the changes in the microbiome that we heard about. Mitochondrial damage, which may actually explain why it's causing damage in the liver, and also elevated 8-hydroxy-2-deoxyguanosine, or 8-hydroxy-DG, which is a marker of DNA damage. So that can also play a role there. So harm can vary, right, in each of us, because that's why we're here talking about personalized nutrition, personalized detoxification. No two people are going to be the same. The amount of damage that's already in their body, the toxic soup that already exists in their body is going to be different. So age and mode of exposure, number of repeat exposures, quantity of exposures, all these things are going to make a difference. Different modes of exposure, we get it a lot of different ways. If you have animals and you walk them through the park, they can't take off their shoes when they get home, can they? So they're going to be bringing it in with them if they roll in the park and everything else. So what things should we think about clinically? So these are some early diagnostic factors that may show up. Respiratory distress, asthma, allergies, metabolic acidosis, tachycardia, elevated creatinine, hyperkalemia, gastrointestinal disorders. It can be so low level that it just shows up like anybody who's chronic issues that show up in our offices. Some more signs and symptoms: fatigue, depression, edema. I mean, really? Difficulty losing weight? So unfortunately, these folks, difficulty losing weight, end up with someone who's going to help them on a weight loss program, and we start to break down fat. We release those toxins, and all of a sudden, it gets even harder, right? Because there's more that's hitting the liver and hitting the stream. So the patient may visually appear healthy and strong, while inside things are breaking apart. This is like the silent epidemic that we see with our chronic illnesses. But what I looked at when I started to measure one patient over 2 years, we did a pre-test, we did several post-tests, several different treatments. We'll go through what those are. I replicated Gerlach in a human because I wanted to see if it worked in cows. And honestly, every time I went to these conferences and they're like, okay, so here's what you do. You use the humic and fulvic acid, you use this, you use this. I'm like, that's what they used on the cow. So we used it. We wanted to see. But these are some of the things that we saw on the prior clinical labs. So big elevations in aspartic acid and beta-alanine and ethanolamine, and then mild and moderate elevations in some of the others there. And some of the things I didn't think to put in the presentation because I was on a short time limit, I've thought about introducing now because I could skip a bunch of the other stuff since you got to hear it yesterday. Here's some of the more other elevations that we were looking at. And you can see on the 8-hydroxy-deoxyguanosine at the bottom, 8-hydroxy-DG was moderately elevated. So it bore true what was shown in research in this particular patient. But my point being, we also did one of the toxin panels that's out there in the display room for you guys, and we ran that, and on the first run, everything came back really clean. In fact, I talked to some of the doctors in charge of the lab and said, gosh, the tox panel is completely clean, like everything's so low, it's below the measurable level or in the green, but yet look at the glyphosate, it was quite high. I don't understand. And he said, wow, that's one of the cleanest tox panels I've ever seen. Is this person eat organic? Yeah, but they live in California, so they're exposed to the water supply, so I guess they're getting exposed to glyphosate, but it didn't sit well with me because I know what we've all been hearing. It's not out there by itself. It's not the only chemical that's in the water supply. It's not the only chemical that's overspraying into organic crops and other things. So we didn't find out until later measures that after treating with the, I'll go through, but after time 2, when we started the detox protocols, all of a sudden we got back a tox screen and the levels were super high. I called back the doc to the lab and I said, this is the same patient. Glyphosate's going down, but now all of a sudden all of the chemicals are showing up high. Well, until we started getting them detoxing at all, we didn't even see the other chemicals in their urine while we could still see glyphosate. So is it the canary in the coal mine, right? We can measure it in urine, but we may still be removing glyphosate while we're holding on to all the other stuff. So again, it's not all about glyphosate, but it was the canary for this patient. It got us acting on something that we otherwise would have said, perfect patient, completely clean, right? Look at how beautiful, best example ever of a tox screen. No. So here's the timeline. We did a pre-test in the very beginning, which showed elevations of urinary glyphosate. And then over a period of 1 year, we did 3 different treatments with a 30-day washout between each period. And 1 year following the final treatment, we did another measure to find out where the glyphosate was going from there. So treatment A was 90 days long, followed by a 4-week washout period. And that was similar to the Gerlach study. And so that included activated charcoal at the dosing as shown on the screen. It included humic acids, it included sauerkraut juice, it included chlorella. So it's kind of a different timing. Again, it was set up really close to the study, but the dosing was adjusted to a human weight instead of a cow weight. That would have been a lot of sauerkraut juice. And then after treatment A, we measured again. So throughout the treatment, the patient reported no change in symptoms, but no negative symptoms were experienced. But we saw on remeasure very little change in the glyphosate levels. And so that can show you right there, 1.45 micrograms per gram of creatinine as compared to the initial measure, which was 1.5 micrograms per gram. And then I said to the patient, well, clearly that didn't get us anywhere. So let's go ahead and try something different if you're game. And they're like, of course. So we used what was at the time an available detox protocol that was out there, switched up a little bit, which included a silica binder, clearweight cofactors, which was like a liver support, okay? Actually liver and kidney. There was some zinc, liposomal vitamin C with R-lipoic acid, and liposomal glutathione. And the dosing is written there, and we did that for the first 4 weeks, and then the second 5 to 8 weeks, we upped it, and then again, weeks 9 through 12, we increased it a little bit more. So you can see I highlighted in yellow the nutrients that changed, the dosing that changed. And what we saw is within the first 30 days, the patient reported decreasing symptoms, better energy, sleep quality, improved focus, and the only negative symptom was reported on day 4. The patient woke up feeling a little bit sluggish, heavy eyes, mild headache, kind of felt like light fluish, or they got hit by a bus, kind of, just slow. And so we modified the protocol a little bit for the first 2 weeks to accommodate for a slower implementation. So when they said on day 4, I forgot feel like I got hit by a Mack truck. We just considered that the first 5 days, we had their 2-day off period. And then, so in other words, first week was only 3 days because they woke up on day 4. So the next period of the 5 days was reduced to 4, and then they took their 2 days off, and then they did the next 5 days, right? So they shortened the first period, but then they added on another 5 days. So I know it confused, but so it was 3 days, 4 days, and then the 5. So they did that. So what we saw at post was a more meaningful decrease in the glyphosate level. So it went down to 1.2 micrograms per creatinine, and there were no further symptoms experienced. So the patient said, well, we got like almost a 50% movement on the graph, the chart that they show you with this treatment protocol, and then you had me stop. Would it help to do it again? And I said, well, it wouldn't hurt. Let's take a 30-day period off, give your body a break, give yourself a washout period, and then we'll do it again. So we did the exact same protocol. However, they didn't need to do the delayed start again. They were ready to just go right back into it, and they didn't have any negative symptoms at all. The patient reported even further improvements in energy, better sleep, brain focus, and the post-treatment levels went all the way down to 0.55 micrograms per gram of creatinine, so great improvement. But we also saw movement on all the other markers, right? Which, again, I didn't put all that in the presentation for a lack of time, but I can pull that all up because we did the total tox screen in the initial, at the 1-year mark, and at the 2-year mark, so we could kind of see what was happening with all of that. So with the 1-year follow-up, so again, no treatment during that next year, the patient continued with a fairly organic diet, occasional eating out of the home, but otherwise organic diet, filtered water, no use of glyphosate at home or in the products. And they started getting symptoms back after about 10 months. And so we did another retest, and their levels went back up to 1.35 micrograms per gram. Not as high as at the original reading, but that tells us kind of where they were going, that even with an organic diet, their levels were still elevating. So there's a graph for you, kind of the changes. And the biggest thing I walked away with is just a whole bunch more questions, right? This was only one person. Is it going to happen again in other people the same way? How do our genetics, gut and kidney health, liver, and other variables play a role in our detoxification efforts? And would use of different products work out better? We're trying that same protocol now with the same patient using a different binder, mixed binders, so not the silica, but a different, just to see how it works similarly or different. Yeah, so I encourage you all to try it in your own offices with your own patients, see what moves the trigger. What can we do to improve our own patients' health? And let's step out of our own environment and start helping with some of the community engagement and global engagement that we've been hearing about today, because it's going to take an army of us to make a dent in what is our policy on health and food, right? We all know it greatly impacts our patients. So thank you.